Hello, Northzone staff. We have another education package for you all as a big review on our pain management in EMS. This is going to be a little bit of a longer one, so feel free to watch it in sections when you have a little bit of downtime. Worry not, this does come with some perks. We are going to be rolling out some new medications in this zone, and this is going to just kind of help everyone get a little bit more familiar with those options. So let's get started. So what exactly is pain? The best answer for this is going to be a subjective experience. Ask any person anywhere and they will have a slightly different answer for you. Pain is what each person perceives it to be based on many different factors, which we'll talk about. This is something that we're going to circle back to several times in this video, and there's a good reason for that. If you go ahead and ask Google, like we do for so many other things, you will find this definition of pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pretty broad strokes happening in that definition, and definitely focuses more on pain as a tangible physical sensation. Circling back to my statement, if you walk into the grocery store and ask 10 random people what pain is, good chance that some of them won't even mention physical pain. Emotional pain can be just as tangible and is worth mentioning, even if this presentation is going to focus more heavily on physical pain. Even the emotional aspect of physical pain is something that we find ourselves managing frequently, and it's important that we educate ourselves on both sides of that coin. And this is why pain is the most common reason that patients seek medical attention, either from EMS or the emergency department. Someone could be sick for days, but the primary reason that they'll go and get checked out is because the associated pain becomes too much to handle. This is one of the most common complaints that we deal with in EMS, so how can we do a better job of managing pain? So is pain a bad thing? Of course it's not pleasant. I'm sure everyone would rather have much less pain in their lives. So why hasn't medical science just gone ahead and eliminated pain? Because like most things, we have to take the good with the bad. You don't have to pick a team, but if you said, no, Vicky, pain is good, you're not wrong. Without pain, we would have no motivation to withdraw from noxious stimuli. If I found myself too lazy to walk to the cutlery drawer, I could reach into a pot of boiling water to check if my dinner was done cooking. I wouldn't be fazed, but would I be uninjured? No, I would likely be more injured because nothing was telling me to take my hand out of the water. Then once I've treated my significant burns, what is going to remind me to protect it during the healing process? The absence of pain means that I won't know when I'm aggravating the existing injury. I would continue to use my injured hand, probably continue to open up new wounds, and likely not notice if it begins to get infected. Lastly, pain always serves as a good reminder to avoid that same situation in the future. A year later, I could find myself in the same situation, too lazy to get a spoon, but what is likely going to stop me? The memory of the unpleasant pain that I've already dealt with. In a more disease process type of example, pain can also be a great warning sign, often being the primary reason that cancer diagnoses are made early. But is pain bad? Well, obviously we aren't fond of the actual sensation, but what else is pain producing as a byproduct? We can expect to see some physiologic changes in some patients that are having pain, and depending on their pre-existing conditions, these changes could be quite detrimental. Pain is known to increase blood pressure, heart rate, respiratory rate, and all of these things would make it difficult for a cardiac patient to stay hemodynamically stable. Pain can also cause increased muscle tension due to guarding or spasm, and of course this can lead to more pain. Pain can also cause acute anxiety, with chronic pain being a major cause of long-term depression. There are many different ways of classifying pain. The most common is going to be acute versus chronic pain. While classifying pain isn't necessarily a top priority in emergency response, it has its place when deciding a course of treatment. Dependent on some other factors, acute pain typically responds well to pain management strategies. Acute pain is usually short-term, caused by an acute injury or change in the body. It typically comes on suddenly, reduces when the illness or injury is treated. Relatively speaking, though, acute pain can last upwards of a few months. Take a broken leg, for example. Obviously, when we have the initial acute pain, when the bone is broken, tissue damage around the break becomes inflamed. That is considered to be acute pain. When the patient comes out of surgery with a fixed leg, the pain is significantly decreased, but we can still expect to see some soreness and aching, maybe occasional sharp pain while the bone heals. This can take a few months and would still be considered acute or subacute pain. On the other hand, EMS can also frequently deal with chronic pain. Basically, pain is classified as chronic if it lasts much longer than the expected recovery time. If we take the broken leg example from the acute pain slide, that patient has had their surgery, acute pain has significantly decreased, with the expectation that in about 2 months they will be pain-free. But as time goes on, the patient continues to have aching and soreness, which affects their ability to ambulate as they used to. This is now going to be considered chronic pain and, as such, acts a little differently. Chronic pain tends to resist medical treatment for a multitude of reasons, and for this reason, EMS may opt to dose on the higher end of a weight-based calculation. This is not necessarily wrong, especially if you're sticking to your care maps, but just being aware that chronic pain may not respond to medications as we expect is part of educating ourselves on pain management. Chronic pain is often associated with long-term illnesses like cancer, arthritis, autoimmune diseases, etc. This, coupled with being in pain nearly constantly, can make these patients more susceptible to psychological consequences. These patients may have lost hope for a comfortable life, leading them to anxiety and depression. Acknowledgement that these conditions can amplify pain can also help us to provide better support to these patients. Empathy is going to get you a long way with your chronic pain patients. Pain can also be classified by the damage that causes it. We're going to do a quick breakdown of each category. Again, in terms of patient care, classification of pain is not always at the forefront of our minds, but can influence how we choose to treat the patient. The three categories that we are going to quickly cover are nociceptive pain, which is caused by tissue damage, neuropathic pain, which is caused by nerve pain, and psychogenic pain, which is caused by psychological factors. Nociceptive pain tends to be the kind of injuries that we think of when we think of the primary function of EMS. When dealing with a patient that has nociceptive pain, we can further divide this into subclasses according to the mode of noxious stimuli presented or the type of nerve receptors that are being affected. So in this case, we can be looking at a thermal injury, mechanical injury, or a chemical injury. When we hear chemical injury, of course, our minds immediately go to exposure of chemical substances. We also need to be considering pain caused by chemical responses in the body. Lactic acid from a crush injury, for example. Nociceptive pain can also be subclassed into somatic or visceral. To expand on that slightly, we can have superficial or somatic nociceptive pain. This is going to be your mild to moderate scratches, scrapes, cuts, burns, surface level injuries. They're clearly localized, very easy to find, assess, and treat. As opposed to our superficial nociceptive pain, we also have deep somatic pain. Just like our skin, we also have pain-sensing nerves in our ligaments, tendons, bones, blood vessels, fascia, and muscles. Pain to these areas tends to present as more of an aching pain and is much more difficult to localize. The last classification of nociceptive pain that we're going to talk about today is visceral pain. While this pain tends to be similar to deep somatic pain in the sense of the aching and cramping feeling, there are some differences between the two. Visceral pain originates in your organs. Because there are significantly less pain receptors that are also grouped differently, visceral pain tends to be pretty difficult to localize. Patients will often describe it as more of a dull aching or cramping, or may describe it as an all-over pain. When this presentation was originally given, Jerry gave a good example of visceral pain being appendicitis pain. We know that the hallmarks of appendix pain are lower right quadrant pain, and rebound tenderness, but not all APIs present this way. In the early onset, these patients will describe a dull, all over my stomach type of pain because all that's affected is the organ. The patient is only feeling visceral pain. As appendicitis progresses and inflammation increases, somatic pain receptors on the peritoneum are affected, causing a more sharp and localized pain over the lower right quadrant. When we're dealing with visceral pain, we also need to be aware that there is a high probability of referred pain. Classic example of this is the neck, shoulder, jaw, and arm pain that can accompany cardiac pain. Neuropathic pain is a category all its own, and luckily it's usually pretty easy to spot. Neuropathic pain can be divided into peripheral and central, so two subcategories, but the way that patients describe neuropathic pain is what really sets it apart. Your peripheral and neuropathic pain is often described as that burning, tingling, pins and needles, sudden sharp stabbing pain. And it's true, other types of pain can produce that stabbing sensation, but it's usually a pretty good indication that you're dealing with neuropathic pain based on that pins and needles feeling and the ongoing stabbing sensations. Central neuropathic pain is often described as a burning, a stabbing, a lacerating pain, a pressing pain, aching, prickling, or tingling. And the thing with central neuropathic pain is it can be quite over heightened. It can seem like your patient is in a lot more pain than they should be. So you don't expect them to be in an 8 on 10 pain, symptomatic of that, but they are. They're complaining of an 8 on 10 pain. They look extremely uncomfortable. Neuropathic pain can be caused by a whole multitude of things, really. Different kinds of ischemia, some compression, even metabolic injuries. Diabetic neuropathy tends to be a pretty good example of this. Your longtime diabetics or uncontrolled diabetics will often complain of that peripheral pins and needles. There are actually some chemotherapies that cause this as well. So it's a good idea to usually ask your patient what their history is. And this is also a really good indication of what kind of pain your patient is experiencing and whether or not we expect it to be neuropathic. So I am admittedly no neurologist, but for the sake of this being a pain presentation, we do need to talk a little bit about pain pathways. We've already covered the different types of pain receptors in the body. So in this diagram, it looks like this patient has suffered some sort of injury in the wrist, poked by something, which is going to be stimulating the nociceptors in the skin where that tissue damage is occurring. This can happen in a variety of circumstances. Maybe you touched your hand to a hot stove. Each one of these pain receptors forms one end of a nerve cell. The other end of the nerve cell is connected to the spinal cord by a long nerve fiber. So we can see number 2 here is showing a pain pathway up that patient's arm. Little arrows are showing that those pain receptors are heading towards the spinal column. So almost like a tiny cable running from one point to another. The nerve fiber is then going to be bundled up into a group to form a peripheral nerve. That electrical signal stimulated by the tissue damage is going to travel up the peripheral nerve to reach the spinal cord. In the spinal cord, those electrical signals are transmitted from one nerve cell to another. And then it's at that point that they make their way up the spinal cord to the brain. Once those pain signals reach the brain, they're going to pass through the thalamus, which I believe Jerry likened to the sorting station of the brain or the mailroom of the brain. The thalamus is going to take those pain signals and it's going to send them out to all the different areas in the brain and the body that they need to go. So they're going to be sent to the somatosensory cortex, which is going to be what provides that actual feeling of pain, that tangible feeling of pain. There's going to be signals sent to your frontal cortex, which is in charge of thinking. It's going to be telling your body, oh, we need to pull away from that noxious stimuli. And there's going to be signals going to the limbic system, which is linked to our emotional response to that pain. So as you can see, this is no easy process, not a simple process at all. And if one aspect of this pathway is hindered, then your body's not able to properly respond to a painful stimulus. This is why there are so many different pain medications with different mechanisms of action. So we can have a different mechanism of action for, say, an NSAID pain reliever, which would be drastically different from something like a nerve block. Um, it just kind of depends on where you're breaking up that pain pathway in the body. So we're going to dive a little bit into prostaglandins in the context of how do a lot of our pain medications work. So prostaglandins are a family of chemicals in the body that trigger our inflammatory responses. So when our body triggers an inflammatory response, it's meant to be a protective mechanism. The problem is when our inflammatory response goes too far and now has the potential to cause damage. A good example of this is fever. A little bit of fever is a good thing. Creates a hostile living environment for foreign organisms in our body, for viral infections, bacterial infections. But too much fever now has the potential to cause brain damage, and we have to step in at some point and stop that. Prostaglandins also support our blood clotting function, our adhesion of platelets in the body, and they also protect the stomach lining from acid damage. So they protect our stomach linings from our own stomach acid that we use to digest our food. Essentially, they're pretty helpful chemicals to have making their way around our bodies unless they start working a little bit of overtime. So prostaglandins are produced in the body's cells by the enzyme cyclooxygenase, or COX1 and COX2. Both of these enzymes promote inflammation, pain, and fever. Not super important to know, but just kind of a nice to know. So why exactly do we care about prostaglandins and cyclooxygenase enzymes? Mostly because this is how many of our medications in EMS act on the body and treat pain. We have multiple NSAID pain relievers in our scope, and knowing their effect on the body can help us make some more informed treatment decisions for our patients. When we administer an NSAID to a patient in pain, these NSAIDs will work by blocking those COX enzymes and therefore reducing prostaglandin release, which is going to result in a reduction of the patient's pain, fever, and inflammation. That's a good thing. However, we also need to remember the good things that prostaglandins were already doing in the body that they're now going to be inhibited from doing. Patients that receive NSAIDs for pain relief can have resulting damage to the stomach lining, especially if they chronically use NSAIDs at home. At the very least, patients can expect some mild abdominal pain. NSAIDs will also promote bleeding now that prostaglandins are no longer promoting platelet adhesion. This is important to know for the context of indications and contraindications of NSAID pain relief in patients. Most of us know that ASA is likely to cause bleeding due to it being a platelet aggregator, and we wouldn't administer it to someone with evidence of bleeding. However, ibuprofen is the only NSAID in our care maps that lists trauma or active bleeding as a contraindication to administration. Now we know that bleeding, or the potential to be bleeding, is something that we should probably be taking into consideration before the administration of ketorolac as well. And while we're talking about contraindications, ibuprofen and ketorolac also have pregnancy listed as a contraindication for administration. This is because prostaglandins are actually also responsible for inducing and progressing natural labor. The administration of NSAIDs can slow down the labor process. I think we know that late-term pregnant patients just generally have a lot of muscle soreness and pain, but I can assure you they would much rather just give birth than try to manage that discomfort with an Advil. We do have some opioid options for actively laboring patients to be used with caution, which we can talk about later. There are obviously a lot of other reasons that Advil and ketorolac might be contraindicated for use in pregnant patients. There are some studies showing some potential defects caused by use of Advil throughout a pregnancy. But in terms of why we're not using it when we are treating a late term pregnant patient or a laboring patient, this is why we want to avoid NSAID pain relievers for those patients. So let's get back to talking about pain in general. Let's pose a question. Why do patients undergoing the same surgery or suffering the same injury report vastly different levels of pain? Let's think about that for a second. So if we dive a little bit further into that and give ourselves an example, let's say that these two gentlemen presented to the same hospital for the same day procedure. They're approximately in the same demographic. Um, but we have our patient on the left who looks to be coping pretty well post procedure. He's smiling, he's focused, he's sitting upright, whereas our patient on the right looks to be in distress. He's scrunching his face up in pain, he's holding his side, he's not sitting up, he's closed his eyes. He looks to be in some pretty significant pain. So why would both of these patients who have generally the same information be experiencing two different levels of pain? I'm sure most of you probably know the answer to the question that we posed ourselves on the previous slide. Um, But why is that not what happens in practice? I think we all can think of a time where we maybe compared one patient's pain to another patient's pain, and we couldn't understand why there was such a disconnect between the two, when deep down we do know what the reason is. And we're going back to that statement that I made much earlier in this presentation, that pain is a subjective experience. There are many different factors that can alter how a patient perceives pain and how they perceive it differently from one patient to the next. Um, Pain can be influenced by many different factors. There are biological factors in play. There are psychological and emotional factors in play. Maybe you have a patient who has a long-standing history of chronic pain. Therefore, they have a lower pain tolerance. They have a lower threshold, but they have a higher pain tolerance. So this is going to change how they perceive that pain. Um, Maybe we've got some social and cultural factors in play. We're going to talk about it a little bit here coming up, but there are some different groups or clubs or demographics of people who will maybe not necessarily perceive their pain differently, but they will show their pain differently for a multitude of reasons. We'll talk about it. And of course, pain is a subjective experience that can be influenced by that individual's experience with pain. So if that patient has a history of some really horrific injuries, they have a long-standing history of a chronic illness, um, maybe they are going to tolerate that pain a little bit better. So we need to take into account that every person is different. Every person has a history. Every person has a way that they allow pain to be shown. And we need to take that into account with our assessments as well. So let's talk about what exactly I mean by cultural or societal factors for the way that patients can perceive or present their pain. Everyone loves to get into the debate of hockey versus any other sport when we're talking about athletes and how they treat their injuries. We're going to use basketball as an example here. I believe when Jerry first did this presentation, he actually coined the term LeBron James face. So we can go ahead and continue using that term here. On the left-hand side here, you can see LeBron James being carried to the locker room. He's got leg cramps. He looks to be in some big pain. But in the bottom half of that picture, we've got a hockey player. I can't quite tell who that is, but comparatively, this athlete has played game 6 with the following injuries: a broken rib, torn cartilage, a separated shoulder, a punctured lung. And there's a little note at the bottom saying hockey versus basketball, discussion over. Why do you think that this might be, that like LeBron James can have a leg cramp and be carried off the court, but this hockey player can play through an entire game with these injuries? Um, Barring the known use or overuse of pain medications in hockey, why else do you think this might be? It's pretty commonly known that in hockey there is a little bit of a cultural factor. The term buck up or um, man up, whatever it is, comes to mind. Frequently, hockey players are just expected to play through these injuries. Um, they're encouraged to. Whereas maybe in basketball, they're not as encouraged to do that. They're encouraged to report their injuries, get them properly treated. They're not looking to hide the fact that they're injured. So we can see that there's a big difference in the presentation and possibly even the perception as well, because these hockey players have been encouraged to just ignore it. So that's what they're doing. On the right-hand screen, we see here again, we've got a basketball player and it says tooth pain, out for 3 weeks. And then in the bottom half of that picture, we've got another hockey player who is pulling his teeth out on the bench and allegedly doesn't miss a shift after doing that. Fair enough, I'm impressed too. But again, we're talking about a cultural difference there. So hockey players are, again, encouraged to just take their injuries as they come, ignore them, stuff them down, continue, get back out there, man up. When we're talking about how pain affects different people in different ways, we also need to consider differing pain thresholds and pain tolerance levels. Chronic pain patients, for example, can have a much lower pain threshold because they process pain quickly, but a higher pain tolerance because they're used to living with pain and have adapted to it. So a pain threshold is considered to be the level at which we feel a stimulus is painful. Because chronic pain patients experience pain so much more frequently, they can identify it much more quickly than an acute pain. That's not to say that um, a patient with, let's say, a femoral fracture is not going to identify that pain quickly. That's just silly. Um, but we need to take into account that our chronic pain patients will identify a much smaller stimulus much sooner than somebody who doesn't necessarily have chronic pain. And then because they are so used to having pain, their pain tolerance is actually higher. So pain tolerance is how much a person can take before breaking down. How long can that patient endure that pain before they break down? Chronic pain patients are much more well practiced at that. So actually, while their threshold is lower, their tolerance is so much higher. So I'm going to circle back to a question that I posed much earlier in this presentation. If we know that everyone reacts differently to pain, then why do we expect every pain patient to present the same way? So we've talked a lot now about different factors that can influence a patient's pain thresholds, how they present their pain, how they perceive their pain. But why do we still expect everyone to act the exact same way when in pain? You'll frequently hear healthcare practitioners say, well, they couldn't possibly be in pain because they're doing this. They're not doing this, whatever it is. We know realistically now that not every patient is going to do the same thing. So it's really going to come down to an appropriate and a thorough assessment of each patient and their history to really give us a good picture of how much pain this patient is experiencing. I say how much pain a patient is experiencing, but what it's really going to come down to is how much pain is that patient saying they're experiencing. Some lucky employees recently had the opportunity to take PHTLS, so this is going to be a little bit of a review for these employees. As with all patients, we want to make scene safety a priority with every call we go to. A common cause of patients in pain is, of course, trauma or violence, and we can't help anyone if we also become patients in the process. Before we even reach the patient, we can already be gathering a general impression. Is your patient making noise or moving? Can you see any color changes in skin? Can you see any active bleeding? Can you hear anything coming from that patient aside from any moaning, screaming, whatever noises they're making? Can you hear anything? If we're talking about traumatic pain in a patient, we still want to assess our ABCs with an addition of X for major external bleeds. Immediately following this assessment, we are going to treat immediate life threats. So if we identify any deadly bleeds, airway compromise, breathing compromise, circulation compromise, we're going to step in at that point and treat those threats. Following this primary assessment or initial assessment and any treatment of life threats, we can head into our secondary assessment and get some vitals. This is where we're going to gather some more specific information on what our patient's experiencing and make some appropriate decisions for their care. Since we mentioned a secondary examination of patients, let's talk about secondary exams in the context of a patient in pain. So a helpful mnemonic that we've all been hearing since forever has been OPQ or ST, which is still super relevant for any kind of pain that a patient is having. So we can be asking about their onset. So what were they doing when the pain was first noticed? Did it come on abruptly or gradually? How long ago? Um, is there anything that causes that pain to get worse or better? So P is provocation or palliation. We're going to ask, does palpation make that pain better? Does it make it worse? Does movement make it better or worse? Q is going to be for quality. Describe the nature of the pain. So we always ask patients this. Can you describe to me what that pain feels like? Is it sharp, well localized, dull, cramp-like, diffuse, that all over abdominal pain? This is going to help to separate our assessments between possible visceral pain or possible somatic pain. Does that pain radiate? So R is going to be radiation, region, rate. Where is that pain? Does it spread anywhere else? S is going to be severity. So use a reliable and validated pain scale to help the patient explain the level of pain they are experiencing. And whatever that patient says their pain is, that's what it is. And lastly, T is going to be time. So we already kind of covered it in onset, but just for good measure, how long has that patient been having this pain? Ask them to describe how the onset occurred, when, how long they've been having it, what they were doing. Have they ever experienced similar pain? I find that's a really helpful question. So have you ever had a pain like this before? And what caused it? Um, when you had this pain before, what helped the pain go away? This is all very, very helpful information when we're assessing the patient in pain. We're going to quickly cover some validated pain scales. So as I mentioned in the previous slide, we always want to be asking our patient about the amount of pain that they're perceiving themselves to be in. And there's a couple different ways that we can go about that, maybe depending on some things like language barriers, age, cognitive abilities. Um, we need to be asking our patients and trying to get the best picture of what exactly they're perceiving. So the most common strategy that we use in EMS or in healthcare in general is the verbal numeric rating scale. So we ask our patients to rate their pain on a scale of 0 to 10, which actually makes it an 11-point scale. I'm not going to get picky, but this is what we're dealing with. So 0 is an option. We need to be explaining to our patients that 0 is no pain at all. 10 is going to be the worst pain imaginable. So why do we not to want use other sources of pain as examples? We're all guilty of it. I have done it so many times I can't even count. We'll say to our patients, okay, can you rate your pain for me on a scale of 0 to 10, 0 being no pain, 10 being like childbirth? We'll describe it, we'll compare it to something that we consider to be significant amount of pain. This is a little bit of a flawed approach for a couple of reasons. We could be speaking to, for example, let's say a man. A man has never experienced childbirth. How could he know what to compare it to? Maybe we're talking to a patient that didn't have an unpleasant childbirth experience. This is probably also a different kind of pain that this patient is currently experiencing. It's hard to compare the two. It's hard to compare the pain of a broken limb to childbirth. It's going to feel different. Um, Maybe that woman that you're dealing with has given birth, but also had a significant accident, an MVA, where she um, had some bilateral femur fractures. So, would they perceive the femoral fractures as worse? Probably, but you've just asked her to compare it to childbirth, so she might actually rate that pain a little bit lower now. We're going to try to not give our patient examples of the worst pain ever. We want to just kind of vaguely leave it at 10 is going to be the worst pain that you can imagine, and see where we go from there. So while this is the most common pain scale used in healthcare, it can have its drawbacks or its cons. A patient with decreased cognitive ability may have a hard time understanding what you're asking them or giving a rating. Language barriers can also complicate the use of this pain scale. We're going to quickly cover some other methods of assessing and quantifying a patient's pain that are a little bit alternative from the verbal numeric rating scale, and some other options to just keep in our back pocket. So if we need to go about our assessment differently for a patient that is not responding well to a verbal numeric scale, we can ask patients to describe their pain with adjectives. We tend to do that pretty commonly anyways, but in the absence of being able to get an actual pain score, perhaps our patient can describe it a little bit better. So there is obviously going to be a big language barrier issue with this one as well. I also find that patients tend to react a little bit more strongly and emotionally to this question. They'll make big emotional comments like, "It just hurts." They're sick of us asking. That's okay. It is what it is. Any way that they can describe their pain is helpful to us. This method can also make it a little bit harder to assess efficacy of treatment with this method. If the patient started with cramping pain and still has cramping pain, we can perceive that our patient isn't helping or our treatment isn't helping. If the patient begins with an 8 on 10 cramping pain, but then reassesses at 5 on 10 cramping pain, it's a little bit easier for us to perceive an improvement with treatment, and we know that we're headed in the right direction. All right, so we also have as a tool in our toolbox a visual analog scale. This is more or less a visual use of our numeric rating scale. It is worth a shot to try and use this with a patient that's having a hard time visualizing and quantifying their pain verbally. It's also really useful for patients that might be hard of hearing for them to just visualize that scale. Often this scale is used in conjunction with the FACES scale, which is covered on the next slide. I'm sure everybody has seen it in facility before. This method also has the added benefit of being useful for patients 7 and up. Essentially, you're going to show the patient the visual scale, point out 0 as being no pain, and 10 being the worst pain imaginable. Then ask them to mark where they feel their pain falls on the scale. And here is a visual example of an analog scale. And a reminder to still attempt to ask your patient to describe their pain. So this is actually a really handy visual tool here, because even if your patient is hard of hearing, you can still point out this section at the bottom saying to ask your patients about their pain. So we can point out the different keywords here and see if our patient has anything to add to that assessment while we are showing them their visual scale. Most of you have probably seen this scale used in facility. It frequently sits at triage desks for children presenting to the emergency room. This scale is commonly used for children as young as 4 who may or may not understand a numeric scale. Asking a child to point out the face that they feel like can give you a generally good idea of where their pain falls on the scale. The scale is listed as useful for children from 4 to 16, so use your judgment on this one. I would like to think that most 16-year-olds can probably start using a numeric scale, but every person is different, especially when they're in pain and distressed and unfocused. The scale has a lot of visual cues for children, with a green happy face indicating no pain or good in a child's mind, and a red crying face as a 10 or bad in a child's mind. The last pain scale that we're going to cover is called the FLAC scale. All of the previous methods that we just covered have been useful for older patients, older children that can likely speak, understand, communicate. But how do we assess the pain of a young child that doesn't communicate and can't communicate what is happening with them? For these young children, we're going to go to the presentation route. It's unlikely that a child that young is purposefully giving incorrect information or has any ulterior motive, which tends to be a bit of a hang up in the visual assessment of pain in older patients. The FLAC scale is built a lot like an APGAR scale in that we have 5 areas of visual assessment to cover, and each of those criteria can give us a score. At the end of the assessment, we're going to add the score together to get a rating out of 10. When assessing the child's face, we're looking for expressions indicating their level of discomfort. When we're assessing the legs, we are looking for position and movement indicating discomfort. If the patient's legs are relaxed, that's going to score a 0. Legs kicking or drawn up in a fetal or a guarding position is going to score a 2. Activity refers to the overall position and movement of the child. If the child's sitting contentedly or moving with ease, that's going to score a 0. Arched, rigid, or jerking is going to score a 2. Note that we're not talking about jerking in the sense of seizure activity. We are referring to that type of motion that a child makes when they are not in control of their movement anymore. They are overcome by the sensation of pain. This is something you will know when you see. Children in this level of pain will also present as rigid because they are instinctually tensing or guarding. Crying is obviously an important piece of criteria when we're assessing children's distress. Children don't often hold back on their emotions. If they feel like crying, they will. That being said, an older child that speaks relatively well may verbally complain, and we are going to count this as crying. If they're not crying, they'll score a 0. If the child is crying steadily or frequently complaining, they're going to score a 2. Lastly, the consolability of the child. So if the child is able to be distracted or consoled into less of a pain response, into being more comfortable, then we can conclude that there is less physical pain than emotional pain. Not that that's super relevant, but we are obviously a lot more capable of treating their physical pain than their emotional pain. Ask the child's parent to attempt to console the child if they aren't already. If this is unsuccessful, that child's going to score a 2 for consolability. Talking about the FLAC scale brings up a good section that we do need to cover about the signs and symptoms of pain. So I know I've said it over and over again in this presentation that everyone is going to look a little bit differently dependent on how they're perceiving their pain. But there are some nonverbal signs that we can add into our assessment or can give us some indication of what's going on. The absence of these signs and symptoms does not necessarily mean that your patient is not in pain. I would say that the presence of these signs and symptoms is actually a lot more relevant. So when we're talking about nonverbal signs of pain, we could be looking for facial grimacing, frowns, that clenched, scrunched up face that the gentleman in one of the previous slides had. They could have LeBron James face. If that patient is writhing or constantly shifting in the bed, they can't sit still, they are fidgety, that's an indication that they're uncomfortable and that they are trying to find a spot to get comfortable in. If that patient is moaning, groaning, whimpering, that's obviously a nonverbal sign of pain as well. Restlessness or agitation, I think, kind of falls into the same category as the shifting, the writhing around. So that patient is trying to get comfortable. They can't sit still because they are physically unable to. Patients that appear uneasy or tense, that can be a sign or a symptom of pain. We talked a little bit about drawing up legs and kicking. Very often patients with abdominal pain will present in more of a fetal position. They'll be curled up. That's an indication of pain. Guarding and withdrawing, of course, are going to also be nonverbal signs of pain that can indicate where we need to look and how we might be able to help. Of course, there are some physiologic signs and symptoms of pain as well. Again, I'm going to mention that the absence of these signs and symptoms doesn't necessarily mean your patient isn't in pain. It just means that their body is responding differently to this pain as opposed to another patient's response. So, some things that we can take into account when we're dealing with the patient that is complaining of pain is, do they have an increased rest rate? Very often they will. Very often they'll be breathing in according to what kind of pain they're experiencing. Do they have an increased heart rate? Increased heart rate can come with anxiety. Do they have peripheral vasoconstriction? So, is that patient now shunting as a response to shock? Are they pale? Have they lost their color? Lots of patients will get pale, they'll have a pallor to them. Elevated blood pressure. Again, that's a little bit of an anxiety response, right? It's not definitive, but does that patient have an elevated BP? Or do they have a decreased BP? Maybe we have a little bit of a vagal response happening in response to some guarding. Does that patient have an increased BGL? This is again a little bit of, it's not as definitive as your other signs and symptoms, but it is something that we can add to our toolbox. Is that patient having diaphoresis and do they have dilated pupils? These are also some very important points to note. We are typically assessing these things anyways, and diaphoresis is something that we can see from quite a ways away. It's something that we're typically seeing during a general impression. And it is a pretty good indicator that that patient is working hard to either mask or just cope with their pain. All of these signs and symptoms are the result of a sympathetic nervous system response. This is why most patients will present differently in this way. Not everyone's sympathetic nervous system responds the same way. And it's for this reason that these signs and symptoms have a very poor correlation to pain severity. As I mentioned in the beginning of this slide, the absence of these signs and symptoms does not mean that your patient is being untruthful or deceptive. Putting all these aspects of assessment together along with our clinical judgment is what we are going to call the evaluation of pain. We're going to take all of those aspects and put them all together. To start this off, I want to plant this pretty significant quote into everyone's thoughts. If there's one thing I truly want you to take away from this video, this is it. If we are asking the patient to trust us and share information with us, then we are responsible for taking that information at face value and using it appropriately. So, as Margot McCaffrey said, the pain is what the patient says it is, existing whenever the patient says it does. All right, while our assessment of patients' pain should be systematic and objective, we need to be forming an idea of what is going on based on assessment findings and the patient's reporting of pain. Because it is technically impossible for us to accurately measure pain, we have to rely on the patient's account. And as we have already established, everyone is going to perceive pain differently. Everyone's going to have a different experience. This means that we can't quantify or compare to other patients' pain reactions when forming that clinical big picture. The use of the pain scale score is but a small piece of the puzzle and makes a good conversation starter. This is where we're going to open up the door to further investigation of a patient's pain, not the end of the assessment. And lastly, it is entirely the patient's judgment of the pain that matters, not the paramedics. If the patient says they're having 8 on 10 pain, it's not up to us to pick that apart. We just have to take our patients at face value. I've beaten around this bush a couple of times now, but it's time to just come out and say it. Healthcare in general fails to adequately provide effective pain relief because we are so preoccupied with making sure that we don't enable drug-seeking behavior, that we actually undertreat real pain more than we overtreat. Sit in on any class of young people hoping to become healthcare professionals, and the conversation inevitably always heads this way. But what about the drug seekers? If you give it to them once, they will continue to abuse the system. I understand. These are very valid concerns. But we can't ignore that statistically we are far more likely to improperly treat pain than we are to improperly treat drug seekers. And I would far rather provide relief for someone that needs it than continue being comfortable up on my high horse. So, this is considered a major barrier to effective analgesia in the pre-hospital setting. We need to be aware of our own preoccupation with potential malingering. The preoccupation over patient malingering is perpetuated by situations where we, the healthcare professionals, perceive there to be a mismatch between the patient's pain score and their presentation. I mentioned earlier that a common example of this is patients reporting a high number on the pain scale, but appear to be sitting comfortably, maybe scrolling social media on the stretcher. While this can definitely be a little bit annoying, we've all been there, especially if the patient is not focused on the assessment questions. This doesn't necessarily mean that they're lying. Perhaps that patient uses the distraction of their phone as a coping mechanism. Perhaps this is a normal behavioral response for this patient when they're experiencing distress. Many people who have experienced trauma or abuse in their lives will shut down emotionally when faced with pain or discomfort. This is just one example of how we really need to shift our focus from patient behavior, because at the end of the day, there is no hard and fast way to prove how much of pain a patient is experiencing. So our preoccupation with potential malingering is so prevalent in the healthcare world that there's actually been research performed on it. And what has that research told us? Pretty much the exact opposite of what we tend to believe as paramedics. Healthcare professionals have been shown to consistently underestimate pain observed in patients. Why do you think this could be? And the degree of underestimation increases as clinical experience increases. We would all like to think that our seniority and experience makes us better through the years, and I'm not saying it doesn't. But we do have a tendency to take a lot of our past experiences with other patients and bring them with us into new different situations. When the experiences have given us a more jaded outlook on things, this isn't always great. At the end of the day, we all got into this career to help people, and if our beliefs and attitudes aren't aligning with that vision, then we need to be asking ourselves how we can do better and how our past experiences are not allowing us to reach that goal. Okay, so with all that being said, I know you are all still thinking about that one patient that you know for certain has a drug use disorder and frequently tries to manipulate situations to get what they are looking for. We may know this because of our familiarity with certain patients. Maybe this patient cut right to the chase and specifically asked for opioids for their minor injury. Whatever the case is, let's clear it up. In some cases, we can make the clinical decision to withhold pharmaceutical treatment. Every situation needs to come with a risk-benefit analysis. If you were to once again take an example where two similar patients have two identical minor injuries, but one is complaining of 2 on 10 pain while the other is complaining of 9 on 10 pain, does that mean the one in more pain is lying? Unlikely. There are a variety of reasons that a patient could be perceiving the pain to be much worse. But that doesn't necessarily mean that opioid pain relief is appropriate. Fentanyl for a small laceration is a bit of overkill, and that is something that you can talk to your patient about. There are many different BLS strategies and non-opioid options for pain relief in this situation. Now, what if we take the same two patients and now they both have abdominal pain? Same reports for the pain scale. Can you prove that that patient is not having 9 on 10 pain? Can you prove that he shouldn't be having 9 on 10 pain? The answer to both of those questions is no. So we are left with taking the patient at his word. This is where we can run through a risk-benefit analysis. What are the potential risks of treating this patient's abdominal pain with fentanyl? If the only risk you can think of is that you would be giving a manipulative patient what they want, this is not sufficient. So we have minimal risk with a potential benefit of alleviating this patient's pain. We are well within our rights to try other methods before jumping to fentanyl, but let's be clear, there is never a contraindication to alleviating a patient's pain. If you choose to start with basics and non-opioid options or are feeling like opioids are a risky choice for the patient, this needs to be communicated with them openly and truthfully. And as always, when in doubt, contact online medical support. If you're feeling like there's something a little bit weird about this situation and you don't feel comfortable giving this patient opioids, call online medical and just ask for some advice. Now that we've covered all that physiology, assessment, evaluation, and other heavy stuff, we can get into the more tangible information. While pain is inevitable, we in EMS are very well equipped to treat pain. We are going to be covering some BLS interventions along with pharmaceutical interventions and some newish options that will be available to us soon in the North Zone. Before we cover each of our options, I want to take a moment just to acknowledge the term multimodal pain relief. It's probably something that you have all heard at one time or another, but is it actually what we do in the moment? So some of us tend to limit ourselves in our treatment of pain by picking one avenue and sticking to it. And while it's true that each of these should provide some pain relief, we need to shift our focus to a more multifaceted approach. Maybe manual stabilization of a fracture will provide some significant relief, but that doesn't necessarily mean that we can't provide a pharmaceutical option, or maybe even two. This crossroads approach is not in the best interest of the patient and would be much more effective as a roadway with multiple stops approach. Okay, so we talked a little bit about manual procedures in the last slide, and this is more what I'm talking about. We're going to get right back down to BLS in this slide. So our basic pain management procedures. This is a procedure that, or these are procedures that any one of us can do regardless of our scope. And we know from experience that some of these basic trauma procedures can greatly reduce pain and reduce the need for pharmaceutical treatment. That's not to say that we're going to just skip over pharmaceutical treatment, but it might actually decrease the amount of pharmaceutical treatment that that patient needs, depending on the amount of relief that they get from this. So we talked about it in the last slide, manual stabilization of a fracture. We know from experience can cause significant relief. Then you add splinting and immobilization to that. Those patients can experience a lot of relief just from that very basic procedure. And then we can talk about pharmaceuticals. Wound care, we know that let's use burns for example, treating burns with basic wound care can cause a significant amount of relief for those patients. And then again, we can talk about pharmaceuticals on top of it. Ice and elevation, we can talk about together. I believe those used to come in a handy little mnemonic for injuries in the first aider classes. So the jury has kind of been out on the elevation aspect, I believe more in the perspective of bleeding than anything else. Um, and the research is currently saying that elevation is maybe not the best for a bleeding wound. That being said, there is a lot to say for a position of comfort for a patient. So if they have an injury on a limb and they are just more comfortable with it elevated, that's the goal. We just want them to be more comfortable. So position of comfort is the end goal. And then we can talk about ice. So there's been a little bit of a, long-standing war back and forth between heat and cold. What's best? I believe the research at this point is saying that we want to avoid heat during that initial inflammatory phase. So if we have an acute injury that is now in an inflammatory phase, we actually want to go with cold at that point. Heat is going to be more for those longer term injuries that are not necessarily in an inflammatory phase, but just need some comfort. So we're going to stick with cold for those initial acute injuries. And lastly, we're going to call it BLS, our calm demeanor and reassurance of a patient. We know, again, probably from experience, that things go a lot smoother. Um, Emotions can be brought down a level, even just with our own influence over the situation. So we want to bring our calm to that storm. We want to bring our quiet, our peace, our reassurance, because that patient is going through something that we probably see frequently and they don't. and then not to mention pain and everything else on top of it. We want to be the calm in the storm. We are going to help our patient get through this, and we are going to reassure them of that. We're lucky to have a few different simple analgesics available to us, and the first we're going to cover is acetaminophen. Tylenol is not actually considered to be an NSAID medication, and because of its mysterious mechanism of action, we still aren't entirely sure how acetaminophen works, but the running theory is that it may block those COX enzymes from forming prostaglandins. It may also work peripherally to block pain impulse generation. None of these theories have been proven, however. There is no evidence that acetaminophen has anti-inflammatory properties, but we do know that the antipyretic properties come from action on the hypothalamus. As for indications for use of acetaminophen, they're pretty simple. We are using Tylenol only for mild to moderate pain or fever. Tylenol is contraindicated when our patient is reporting a true allergy to this medication. We also know that Tylenol is metabolized through the liver, so we are going to be contraindicated to use it in patients with this history, with any kind of liver failure. Lastly, we're contraindicated for use in patients that we anticipate having surgery within 4 hours. I believe that this is likely because these patients should be kept NPO, not for any significant reasons, significant chemical reasons. It's just we want those patients to be NPO. Historically, acetaminophen was seen as a relatively harmless, but also kind of useless medication. I might be aging myself a little bit here, but every time I go to give a patient Tylenol, I can hear Dr. Cox in my head. Fortunately, we know better now, and we understand the detrimental effect of acetaminophen overdosing on the liver. Dosing for acetaminophen has always been pretty consistent, but the attitude towards Tylenol still has a little warming up to do. And this largely comes from, people that worked in a time where we didn't have the resources that we have now. Imagine transporting a polytrauma patient. They have multiple fractures. They're bouncing around in the back of the ambulance, and all you have to offer them is Tylenol. I would tell me to get lost too. However, this doesn't mean that it doesn't still have a place in EMS. As for dosing, or the correct dosing of acetaminophen, it's pretty straightforward. Our patients that are 12 years and up are receiving a dose anywhere from 650 milligrams to 1,000 milligrams, and this can be variable dependent on your pharmacy supply. Patients 72 hours up to 12 years old are going to be receiving a weight-based calculated dose of 10 to 15 milligrams per kilogram to a max of 650 milligrams. This means that any child above 95 pounds is getting the full dose of acetaminophen anyways, and some of those older children may actually prefer to take tablets if you have 325s in stock. As with most other PO medications, the onset of action for acetaminophen is around an hour. We have all taken it for one thing or another, and I think we all know not to expect like instant miracles. Dependent on the pharmacy you're dealing with, stock issues, etc., there are a few different options for concentrations of acetaminophen that we carry. Adults can expect to get a tablet, seen in the top right-hand photo there. These tablets are likely coming in either a 325 milligram or a 500 milligram dose. Either of these are going to work for the indicated dose for adults, being that it is 650 to 1,000 milligrams. Fun fact, Tylenol actually hits an analgesic ceiling at around 650 milligrams. So giving an adult either 650 milligrams or 975 is not detrimental. The reason for the increased top dose is actually more for the treatment of fever. Children can greatly benefit from Tylenol admin for a whole variety of issues. Kids get fevers all the time. Kids have teething pain, just a whole slew of things. Their pharmaceutical naivety also means that they typically have a pretty good response to Tylenol. We have two different concentrations of acetaminophen suspension for the littles, and I'd like to reassure everyone that the two different concentrations can be used for any children. It's going to take a little bit of mathing, but the concentration for older children is still usable in your younger children. So the concentration shown here is listed as being for children from 0 to 23 months or up to 23 pounds. This is actually the easiest concentration to use, but it's not always possible. Children above 23 months or 23 pounds can absolutely use this concentration with the same weight-based dose for our care map. For example, my child is 27 months old. She's approximately 38 pounds. This makes her approximately 17 kilograms multiplied by 15 milligrams is going to equal 255 milligrams of Tylenol for her. In a concentration of 80 milligrams per ml, this would mean she needs about 3.1 mLs of the grape deliciousness. This is administered with the included syringe as shown in the bottom right picture there. This, of course, means that this medication is not really sanitary for multi-patient use, and it can be left with the patient's guardian, the entire bottle and syringe. If we were to look at the 160 milligram per 5 ml concentration, or the children's Tylenol shown here, we can see that the concentration just allows for a larger volume. This is not really best for younger children as their primary intake is breast milk or formula, but it is possible to use this concentration if it's what we have. If we were to be dispatched to a 6-month-old child weighing 15 pounds with persistent fever, how would we calculate this dose? The same weight-based formula on our care map is a pretty easy starting point. So we have a 15-pound child converted to approximately 6.8 kilograms multiplied by 15 milligrams is going to work out to 102 milligrams for this child. We know that the concentration listed is actually lower than this dose, meaning this child is not going to be receiving a full 5 mLs. So a little bit more mathing for us. If we divide 102 milligrams by 160 milligrams, we get 0.64. And if we multiply 5 mLs by 0.64, we're going to get 3.2 mLs. So you can see what I mean when I say the smaller concentration is easier to administer, but don't be intimidated if all we can carry is the child size. As with the infant Tylenol, the children's Tylenol can also be left with the patient's guardians. It's also worth noting that that children's Tylenol for the older kids doesn't come with that nice little syringe. It looks like just your regular children's medicine bottle. So I generally find it easiest to pour some Tylenol into the little cup that comes with it and then draw it into one of our empty syringes. This is going to be so much easier to give to a child than it's going to be to ask them to drink it out of the tiny cup. Fortunately, ibuprofen is considered a generally safe medication, but we do have a little bit more to unpack with this one. Being that we do understand the mechanism of action for ibuprofen, we also know when it definitely should not be used. Ibuprofen is indicated for use in patients with mild to moderate pain and fever, same as Tylenol. Due to its known effects on the COX enzymes blocking release of prostaglandins, we also know that it has anti-inflammatory properties. So as mentioned, Advil or Motrin are both indicated for the treatment of mild to moderate pain and or fever. But the contraindications are a little bit lengthier for this one. As always, a known true allergy to ibuprofen obviously means we shouldn't give it to that patient. This also goes for known history of NSAID-induced asthma. When this happens, the patient is essentially having a bronchospasm, which we can just feel free to treat as we normally would. Another big difference with the contraindications of Advil use in patients is with major trauma or other active bleeding. You can use your clinical judgment on this one as the term active bleeding covers a pretty broad range. I wouldn't necessarily avoid Advil over a paper cut, but I might want to consider if the patient is on other antiplatelet medications or anticoagulants. If you think back to the part of this video where we beat the physiology of prostaglandins to death, we can understand a bit more about this contraindication. If you recall, NSAIDs work by inhibiting COX enzymes and blocking the release of prostaglandins. Prostaglandins are actually helping the body to clot by encouraging platelet adhesion. So if we inhibit prostaglandins, we are encouraging bleeding. Advil is also contraindicated for use in pregnant patients. Some sources say that only past a certain gestation is it dangerous, but I think I would err on the side of caution with this one. Advil has been shown to cause fetal renal dysfunction and can cause earlier closure of the fetal ductus arteriosus. Also, as mentioned earlier, NSAIDs can inhibit natural labor, the natural progression of labor. Ibuprofen should not be used in patients with end-stage renal failure, and you may even find renal patients that won't take it even earlier than end stage. Again, err on the side of caution because NSAIDs have been shown to have a detrimental effect in kidney function. It's not listed, but we should clinically be considering liver dysfunction before ibuprofen admin as well. This is covered in the dose section, but for good measure, Advil is contraindicated in use for children younger than 3 months as well. Lastly, same as Tylenol, ibuprofen is contraindicated in patients that could possibly be under anesthesia or having surgery in the next 4 hours. These patients should be kept NPO, and we also know that Advil administration prior to surgery is probably dangerous and could cause some bleeding dysfunction. While not necessarily a contraindication, it is worth noting that patients with GI issues may not tolerate ibuprofen very well. If we once again think back to the functions of prostaglandins in the body, we recall that prostaglandins are protecting our stomach lining from our own digestive acid. Ibuprofen will inhibit prostaglandins and will cause a decrease in that protection, and that's going to cause some abdominal discomfort, nausea, vomiting, or worse in patients that have a significant GI history. The dosing of ibuprofen is again pretty straightforward. Patients 12 years and up are going to be receiving 400 to 800 milligrams. Patients 3 months up to 12 years are getting a weight-based calculated dose of 10 milligrams per kilogram up to 400 milligrams. These can both be repeated every 6 hours if you're on an extended transport. In terms of concentrations, it is a bit simpler for ibuprofen. 200 milligram tablets seem to be the norm for adults and older children, and I think most stations are carrying Motrin for children, Motrin suspension. Concentration dosing math will be similar to Tylenol if you happen to find a station stocked with infant concentration as opposed to a child concentration. For example, let's say we're dispatched to a 5-month-old that is 17 pounds. We're going to first convert that to kilograms. So 17 pounds is approximately 7.7 kilograms. Round that down to 7 kilograms is going to be 70 milligrams. Our concentration of Motrin being 100 milligrams per 5 ml means we want 70% of a 100 milligram dose. So we want 70% of 5 mils volume as well, which works out to about 3.5 mils for this patient. Lastly, as with Tylenol, this medication is to be left with patients' guardians after it has been opened. So if you have cracked open the bottle of Motrin, we are not going to be keeping that as a multi-dose medication. You can just go ahead and leave that with your patient's guardian should they need it at home. Okay, ketorolac, also known as Toradol, is also considered to be an NSAID. This means that it is, or it has a lot of the same information as ibuprofen with a few key differences that we can get into. Ketorolac is indicated for use in patients with moderate to severe pain from an acute illness, injury, or an exacerbation of a chronic condition that is significant enough to require analgesia to facilitate safe and comfortable transport. That's a lot to unpack in one indication. I find a common line of thought is, why would I give Toradol in these cases when I could give fentanyl instead? And as much as we don't love this answer, it kind of depends. While we have the unquestionable effectiveness for pain relief from fentanyl, we also have to remember that ketorolac is an anti-inflammatory. There is a case to be made here for multimodal pain relief if the patient meets the criteria for both ketorolac and fentanyl admin. A good example of this is a patient with a known back injury experiencing an exacerbation. They need to be extricated from their home because their mobility has significantly decreased due to the pain, but extrication is not easy on a patient either. We know the cause of the pain to be a previous injury. This patient could potentially meet the criteria for both ketorolac admin for the anti-inflammatory properties and fentanyl admin for the fast, effective pain relief. I keep using words like potentially and consider, and for good reason. Ketorolac has a laundry list of contraindications and adverse effects that we need to be considering prior to admin. Right at the top of that list is known or suspected ACS or intracranial injury or hemorrhage. The intracranial hemorrhage pretty much speaks for itself. We clearly don't want to give ketorolac an increase of brain bleed. I did have a bit of trouble finding reputable scientific information on how exactly ketorolac can be detrimental to ACS patients, but suffice it to say that the negative effects have been frequent enough to document. Toradol has been documented to cause an increase of edema and hypertension, both of which are not great signs in an ACS patient. It has also been documented to cause dysrhythmias, but whether these were the result of the same mechanism as the edema and hypertension or some other mechanism entirely was not really clear. As with every medication, ketorolac is contraindicated with known true allergies to the medication. We also want a patient history to try and uncover any previous instances of ASA-induced asthma. There's actually some sources that say if the patient has asthma at all, it might not be a good idea to give Toradol to that patient. But again, that is where our patient history is going to come into play. For the same reasons as ibuprofen, ketorolac is contraindicated for use in pregnant patients and patients with known renal failure and renal dysfunction. Again, while it's not listed as an actual contraindication at this time, ketorolac should be used with a high degree of caution for patients with possible bleeding and those who are already taking antiplatelets or anticoagulants. Additionally, medics should do their due diligence when collecting a patient history. We have already spoken about the effects of NSAIDs on the GI tract, but it seems that Toradol tends to carry a much higher risk of adverse effects. This is especially true for those that have a history of peptic ulcers, GERD, IBS, or other diseases of the GI tract. These are patients that we should be considering other avenues of pain relief for. All this information is not meant to scare you away from giving ketorolac. On the contrary, it definitely has its place in emergency medicine. This is more about our due diligence as providers and knowing how our medications can affect a patient in the long and short term. When it comes to administration of ketorolac, it's pretty easy to see the positives for us. We don't have a lot of non-opioid pain medications with the fast onset and documented effectiveness that ketorolac has. It's also great for our multimodal situations, providing a quick onset of anti-inflammatory properties as well. I'm going to take this moment just to bring up a recent staff question that we had. A few others with some keen eyes might have noticed that ketorolac that we stock pretty clearly states for IM use only. It took some time, but we were able to confirm with pharmacy that this ketorolac can be given IV as well. And the reason that was given for this is that Health Canada has only officially approved this medication for IM use. However, it has been well studied and substantiated that ketorolac is safe for IV admin as well. Both modes of admin don't require any dilution, but IV admin should be done as a slow push. The only other note that I would like to make regarding the admin of ketorolac is that it can be uncomfortable for the patient. It's good bedside manner to give your patient a heads up that this may feel a bit uncomfortable when it's being pushed in. Offer them an ice pack if that helps. Assure them that it will pass quickly. This could also be where you may choose to dilute an IV dose of Toradol. So as for dosing, it tends to be a little bit more precise. For both the IV and IM route, patients 17 years and up are receiving a dose of 30 milligrams. Patients 2 years up to 17 years are going to receive a weight-based dose of 0.5 milligrams per kilogram up to a max of 30 milligrams. And children 12 months to 2 years are also going to receive a weight-based dose, but it's going to be of 0.25 milligrams per kilogram up to a max of 15 milligrams. None of these doses have a repeat. This is a one and done medication. Now, I do think this needs to be noted, but noted with a grain of salt, of course. The dosing of ketorolac is a bit of a controversy, especially in areas that have opted on the higher end of dosing like ours. It has been shown that ketorolac has an analgesic ceiling of 10 milligrams, meaning that the additional 20 milligrams that we could be considering or we may be administering may not even have a positive effect on the patient's pain. So it tends to be seen as an unnecessary risk to administer such a high dose for potentially no reason. While I can't change the care maps and we need to follow them, you may want to take this information and possibly consider if it may be safer to give an oral dose of ibuprofen to certain patients. So as helpful as our simple analgesics can be, it's time to get into the more interesting stuff. Opioid medications have been used for well over a century in the pharmaceutical sense, very likely much longer, and even longer by those who have historically populated opium-rich areas of the world. This Bayer ad from 1901 is an interesting piece of history. It gets even better the more you read. Bayer still being a household name shows just how much the world has changed, but also not changed. It appears that heroin was used for anything from surgical anesthesia to pain relief, as a sleep adjunct, to a simple cough remedy. Opium use has been depicted in Hollywood timepieces where characters are shown using opium as a treatment for both physical and emotional pain. Post-World War I soldiers would use opium to attempt to self-medicate away the symptoms that we would now identify as PTSD. The negative aspects are also shown as an elevation of traumatized erratic behavior and addiction. In 1920, Canada passed the Opium and Narcotic Drug Act in an attempt to use prohibition to battle the negative outcomes from opium use in the country. So while pieces like this are pretty interesting and even maybe a little humorous to look back on, the damage has been done for many areas of the world. We have now come a very long way in the research and study of opioids and how they can help or hurt. And now it's our job as healthcare professionals to educate ourselves and do better for our current patients. So we're going to learn a little bit more about the logistics of delivering the opioid medications that we have at our disposal. All right, so when we are hammering out the mechanism of action of our opioid medications, it helps to understand the difference between an agonist, an antagonist, etc. I happened on this graphic in a resource from another zone, and it was actually a little bit shocking how clear this made the distinction for me. This was the graphic that made it make sense. When we're talking about receptors in the CNS system, we can liken them to a lock, which I think is probably a common analogy used for this education. Most locks have a specific key, cut uniquely to exactly fit and open the lock. The keys in this analogy are the natural hormones or neurotransmitters like endorphins, which are natural pain relievers that are produced in the body and fit into those neural receptors. They're made for them. When we're speaking about agonists, we would liken these to the bobby pin. It's not made for the lock, it's not unique to the lock, but it is still capable of doing the job and opening the lock. These would be our opioid medications, fitting into the opioid receptors and providing similar results as natural hormones would. And lastly, when we're speaking about a receptor antagonist, this is where the stick comes in. It's not at all made for the lock. It might fit in there, not well, but it is not going to open the lock either. Looking at this from a medical perspective, Narcan would be the receptor agonist. Not only does it block anything else from entering the receptors, it also removes opioids from the receptors and stops the effects of the opioid in question. The opioids that we use are technically opioid receptor agonists. This means that they are going to enter the body and bind to opioid receptors that aren't necessarily for external medications, but accomplish the same purpose. When opioids bind to the receptors, they are doing a few different things, including blocking ascending pain signals, which is blocking the pain signals from even reaching the brain. They're also altering the patient's perception to the pain and causing an overall depression of the CNS system. So opioids are acting on our patients in a couple different ways, so we can see why they are so effective. The indications and contraindications of morphine and fentanyl are similar enough that we can cover them simultaneously and save a little bit of time. We can also talk about some considerations that don't necessarily meet the threshold for contraindication. So, obviously, the only indication for the use of an opioid is moderate to severe pain. Our care maps give a big, long indication that almost makes it seem like comfortable transport is the only goal. But of course, we know that the end goal is pain that needs to be relieved. That would be our primary indication. The contraindications, on the other hand, are many. Due to the absolute laundry list of adverse effects that can be caused by opioids, we need to have a high level of assessment happening for those patients. A true allergy to morphine or fentanyl contraindicates the use of those medications, but they don't seem to go hand in hand. Some medications tend to warn patients with allergies to steer clear of other medications in the same family, and this doesn't seem to be an issue for morphine and fentanyl. But it's good information to have on your radar. If a patient claims to have a morphine allergy, you can explain the risks and benefits of getting fentanyl for their pain and explain how an allergic reaction can be managed. And at the end of the day, we can leave that decision up to them, or we can offer other alternatives. Um, I would also extend this to a history of adverse reactions after receiving an opioid. So if your patient has previously had an adverse reaction to other opioids, you may want to take that into consideration as well. I have personally had some negative experiences with morphine, have experienced the orthostatic hypotension and the vomiting that can occur. Knowing this might sway my decision to receive or not receive morphine for any future conditions. These are conversations that should be had with your patient if they are capable of engaging in that, and they don't necessarily contraindicate your patient to receive that medication, but I think it's a good conversation to have. Decreased LOC, or known or suspected significant head injury, are pretty good reasons to not be administering opioids, being that both head injuries and opioids can cause CNS depression and decreased respiratory rate. This is not a risk that we should be taking for these patients. Unfortunately, this is also my least favorite contraindication due to the high probability of coexisting injuries in patients that have experienced trauma with significant mechanism. Being unable to treat a painful femur fracture due to a suspected head injury is not a situation I wish on anyone, but we are again doing that risk-benefit analysis. Significant drug or alcohol intoxication kind of goes hand in hand with the decreased LOC. We already have a patient at risk for CNS depression. Adding in a medication that can cause the same is pretty counterintuitive to providing care. And then adding in other substances that can do the same would not be a really great situation. The last two contraindications also go hand in hand. Hypotension, hypoperfusion, hypoventilation, or respiratory failure are all byproducts of CNS depression that will only be compounded with the addition of an opioid medication. It's not necessarily a contraindication, but it is also worth noting that morphine can cross the placental barrier and can also pass into breast milk. So administering morphine to a pregnant woman can have detrimental effects on her unborn child, and she should be aware of them. The same goes for breastfeeding mothers. It's not a contraindication, but should absolutely be communicated to the patient that they will have to consult with their doctor regarding how long they should avoid breastfeeding for. These patients absolutely have the right to refuse morphine if they feel like that risk is not worth it. Fentanyl tends to be a little bit safer for pregnant or laboring patients, but can still cross into placental circulation. There is a risk of small amounts of fentanyl passing through breast milk as well, so as with morphine, please try to educate your patient on potential risks. Remember that if your patient is in pain, it's likely that they're having a hard time focusing. So be clear, be concise, and help them weigh the benefits versus the risk. So as I mentioned earlier, opioids have quite a list of adverse effects, some that aren't even covered on this list. This is important information to be relaying to a patient prior to administration, and important to know how you can combat some of these should they present. So cognitive impairment we will add to the list, but I mean, isn't this essentially one of the goals as well, a little bit of cognitive impairment? It's probably a nice idea to warn a more opiate naive patient about this, but as long as we keep it within the parameters of acceptable behavior, a little cognitive impairment is likely not the worst for a patient in pain. Both constipation and sexual dysfunction are more long-term use side effects. You may see these in patients with chronic conditions that take daily opiates. Nausea and vomiting are pretty common adverse effects of opiate medications, so much so that you have probably worked with a medic that gives opiates and Gravol concurrently. While this isn't necessary and it could possibly be jumping the gun a bit, it's not the worst idea to at least have these supplies out and ready should your patient begin to feel unwell. Orthostatic hypotension, I find doesn't happen as frequently in EMS, given that patients are typically on our stretcher until they get to a hospital bed. However, not all calls are made equal, so being aware that this could become an issue is most of the battle. If you could oblige me just briefly, I did mention that this is an adverse effect that I have experienced, and what some people don't realize about orthostatic hypotension is that it can occur even when you're sitting a patient up in a Fowler's position. Depending on the individual patient, they may know what's happening, give you a heads up, or just go down like a sack of rocks. And here's the interesting part. Remember that nausea and vomiting bit? This is actually more likely to occur when a patient is having a hypotensive episode, meaning you're now going to have a patient that is vomiting and also can't hold their own head up. So fun. And yet another reason that some medics prefer to have the Gravol ready to administer. This feels like a good time to note that this information is not meant to scare you away from providing opiates. It's meant to empower you to provide the best care for your patient. Knowing what could potentially happen and being prepared for it, that's just hands down the best way to provide exceptional care. Addiction, tolerance, and dependence all kind of go hand in hand. And they can come into play in different ways. Most of you have probably attended a call with a patient experiencing pain who refused to receive fentanyl. Fact of the matter is that there are people in this world that have fought one of the toughest battles and come out on the other side. So we need to respect that choice. This is where your alternative medications or methods can come into play. We can offer them other non-opioid options. Increased tolerance can also mean that patients having exacerbated pain may need more aggressive dosing and treatment. And lastly, I know we've mentioned it so many times, but we really do need to be aware of the possibility of opioid-induced respiratory depression. We also need to be aware of the fact that different patients will have different thresholds for respiratory depression. Dose with caution in patients that have a history of adverse reactions, are over 75 years of age, or are opiate naive. Obviously, some of these adverse reactions are much more significant than others. So what happens if we administer morphine or fentanyl and our patient has a sudden decrease in respiratory drive? We do know that morphine is unquestionably an opiate, so Narcan is an effective antidote if we do need to reverse the effects. However, there is still a pretty common misconception that fentanyl is unaffected by Narcan, with some people believing that it falls more into the benzo category. This is fortunately not true, with fentanyl being a synthetic opioid. I think a large contributing factor to this myth is that fentanyl is just so much more potent than other opioids and requires a lot more Narcan, and possibly makes it seem like the Narcan is ineffective, especially if that patient has taken a pretty significant amount. This shouldn't be an issue for EMS administered fentanyl. We obviously dose a lot more carefully than your average street cook, meaning that fentanyl should, or Narcan should be effective in reversing effects with these patients as well. We're going to administer Narcan for any patients that experience a significant loss of respiratory drive or other concerning or unmanageable symptoms. Okay, so morphine can be delivered via the IM, IV, or IO routes and is not available for IN or intranasal administration. If you've had a chance to look at this care map, at first glance, the dosing looks to be a bit complicated. But a closer look shows that generally all doses of morphine are the same, just with different maximums. So for our patients that are 10 years old and up, they are receiving a weight-based dose of 0.1 milligrams per kilogram to a single max dose of 10 milligrams. Again, we have some considerations to make regarding how our patient is going to respond to morphine admin, and we're not required to give a full 10 milligrams, even if our patient weighs enough for it. Patients that are 12 months up to 10 years old will also receive a weight-based dose of 0.1 milligrams per kilogram to a single max dose of 5 milligrams. We also have some difference in repeat times and hourly maximums dependent on the patient age and the route of administration. Intramuscular doses can be repeated in 30 minutes with an hourly max of 20 milligrams for youth and adults, and an hourly max of 10 milligrams for infants and children. IVIO doses can be repeated in 15 minutes with the same hourly max doses. Why do you think this might be? Seems like a good time to talk about one of the biggest positives around morphine versus fentanyl. Morphine tends to have a much faster onset via the IM route and significantly longer period of duration. This makes it super useful in the IFT or long transport setting. However, this also means that we need to be cautious of repeat dosing to avoid compounding effects. Or in English, if we give a second dose before the first dose has fully taken effect, we have greatly increased the patient's risk of having adverse effects. So this is why the IM route has a longer repeat time to ensure that the morphine has had time to take effect and we can be sure that the dose is just not effective enough for that patient. The IV route has a much shorter repeat time only because onset is so much faster and we can more quickly make that determination that the dose has just not been effective rather than waiting for it to kick in. Okay, administration of morphine is pretty straightforward and similar to other medications we already carry. The expected stock is going to be 10 milligrams per ml ampules, and if this changes, then we can just adjust our math. Not all patients could be receiving a full 10 milligrams, so we will be diluting that 1 ml with another 9 mils of saline. This is especially important for those receiving a lower dose because this can ensure some more accurate dosing. Just as a reminder, this doesn't mean that we take a flush and push out 1 ml and then drop our med. This does not provide good mixing or dilution. You will be drawing 1 ml of morphine into an empty 10 ml syringe and pulling the remaining 9 mLs out of a saline bag. And then when this is all said and done, we are going to deliver that dose via a slow push. That slow push needs to be over 60 seconds. So we're going to be pushing that fully diluted dose over 60 seconds, just being aware of how much of that dose we are delivering so we don't just lose track of what we're doing and push the whole 10 when we didn't mean to. Okay, now I know I'm going to break some hearts with this, but morphine is a drug that is only for the ICP and up scope. So you're probably wondering why we're all covering it, and that's pretty simple. Morphine, for obvious reasons, is a high alert medication and it requires a double check. Even if you practice at the PCP level, you may find yourself working with an ICP partner requiring a double check on morphine. So familiarizing yourself with the protocol and the dosing is the best way to support your partner in these cases. Okay, so since fentanyl was introduced in EMS, it has really been favored in this industry because of its shorter half-life, its availability for the PCP scope, and its top-notch effectiveness. As we've already talked about, the indications and contraindications are so similar to those in morphine that we were able to cover them together. The only addition that I would make for fentanyl is the education and reassurance aspect. There has been an aggressive public awareness campaign about the dangers of fentanyl, which is great and much needed, but I'm sure you have all noticed the effect that this has had on patients that could benefit from fentanyl. I have found myself more and more having to explain to patients that we are using a pharmaceutical grade fentanyl that is being appropriately dosed for them. Really needing to walk that fine line between appropriately educating your patient on the risks, but also reassuring them that they are safe receiving fentanyl in this location. It can be difficult for us having the knowledge that we have, so please put yourself in your patient's non-medical shoes and address their fears for them. All right, let's get to dosing. Being that we are much more familiar with fentanyl, this should be a breeze. Fentanyl is also favored because we're able to give it intranasally. This can make it easier to begin getting a patient's pain under control if IV access isn't possible yet. Keeping in mind that we should not do this for our ACS patients. It is always safer to have IV access to be able to correct hypotension. So for our patients that are 10 years and older, we can give a weight-based dose of 2 micrograms per kilogram up to a single max dose of 100 micrograms. Patients that are 10 and younger are receiving the same weight-based dose with a single max dose of 50 micrograms. If we math that out, peds patients that are 55 pounds and over are going to be receiving an entire 50 micrograms, which is not very heavy if you think about that age range. My 2-year-old is around 40 pounds now, so realistically, a lot of patients can easily hit that max dose. What we want to be cautious of is that these patients are likely to be opiate naive. I'm not saying underdose patients because that is a whole other can of worms, but we want to be aware and very cautious of potential adverse effects. We also want to make the parents of the little humans aware too. They should always be forewarned of how their patient or their child could react to the administration of this medication, how we're planning to deal with any of those adverse reactions, and why we feel that the benefits outweigh the risks. Because intranasal fentanyl has a slightly faster onset than IM, but less bioavailability than IV, we are allowed 1 repeat dose in 10 minutes. Keep in mind that if you do get IV access after an IN dose, you may still give a repeat dose. There is no care map direction on a timeline for this situation, so please be cautious of giving a repeat dose too quickly. At that time, hourly max doses would be in effect. IM dosing is similar to IN dosing with the addition of an hourly max dose for each age group. We are now given the option to repeat the dose multiple times every 30 to 60 minutes, as long as we stay within the parameters of the hourly maximums and our patient is tolerating those doses. And IVIO dosing for fentanyl. For our patients that are 10 years and up, we're looking at 0.5 to 1 microgram per kilogram to a single max dose of 100 micrograms, or an hourly max of 200 micrograms. For our patients that are up to 10 years, so younger than 10 years, we're still going to be giving 0.5 to 1 micrograms per kilogram, but they're going to have a lower single max dose and a much lower hourly max dose as well. And then for the IV or IO route, because the onset is so much faster, we are able to repeat that every 15 to 30 minutes as required. So the administration of fentanyl is pretty straightforward, and like I mentioned earlier, it's a drug that we're all pretty familiar with at this point, so this should be pretty quick. We are currently stocking fentanyl in 100 microgram per 2 ml vials and stocking in accordance with controlled substance policies. So these medications require, we require them to either be on your person or locked in a safe, and we require all movements in and out of the safe or administration to be documented on your controlled substance registry sheets. Intranasal administration is definitely a selling point of fentanyl, but it does come with a complication around volume. So our current care map does mention that when we go the IN route, we should be sure to alternate nostrils if giving a repeat dose. But what if we need to give a 100 microgram or a 2 ml dose? It is fine to still administer this route. We're just going to need to give 1 ml per nostril for the first dose and then do the same when we're repeating. That should be enough time for the nares to fully absorb the first dose of that medication. IM administration is considerably easier as the volume required for a max dose can be fully administered into the vastus lateralis. If your patient prefers their IM injections into their arms, be cautious of your patient's size and split the dose in half, with the 1/2 going in each arm if needed. Okay, IV dosing is also pretty straightforward, but it's a good idea to dilute for this one. Onset of IV fentanyl is nearly instant, meaning that we should be administering via a slow push over 1 to 2 minutes and titrating if the patient seems to have any adverse effects. This becomes much easier to do when we dilute the dose and create a larger volume. This is performed the same way as the morphine example used earlier. We're going to draw up our 2 mLs of fentanyl into an empty 10 ml syringe, and then we're going to draw 8 mLs of saline into the same syringe, giving us a total volume of 10 mLs. If your patient is not receiving the full 100 micrograms, the remaining medication in the syringe has to be labeled and properly disposed of if left unused. And of course, fentanyl is a high alert medication, and that requires a double check of dosing. So please be sure to do that and document that on your PCRs. As a final note on our opioid medications, let's touch on our timeline of action for both morphine and fentanyl. Onset of both medications is relatively quick, and if your patient has received an effective dose, they should start to feel it soon. You'll notice that the onset of IV fentanyl is quicker than the onset of IV morphine, and this tends to be another reason that fentanyl is favored in EMS. I frequently joke that we live in the fast lane and we love anything that can keep up with us. That's not a knock to morphine, as we can see that the onset is still pretty fast. IM doses of both medications are understandably going to take a bit longer for onset just due to the route. And interestingly, the IN dose of fentanyl is kind of variable. It could either have a faster or a slower onset than an IM dose. Where morphine is winning the rat race is in the peak effect. I mentioned earlier that morphine does have a much longer half-life, and those of you working in stations that do long IFTs already know this. Patients that are going to be subjected to a long transfer tend to manage that better with a longer acting medication like morphine, as long as they have a history of tolerating that medication. We can see that there is a vast difference between the peak effect of both meds given the IV route, with morphine hitting peak around 20 minutes and fentanyl hitting peak within 2 to 5 minutes. So this is why if you're working in one of those stations that do longer IFTs, longer transports, lots of times you'll see the more experienced medics in those areas actually request that their patient get morphine prior to transport, as opposed to giving them multiple doses of fentanyl during that trip. In other exciting news, ketamine is finally making its return to the province. Stock issues have been resolved and we have been given the clear to start carrying again. I'm not going to be getting too far into ketamine in this video, as it has been very well covered by our friends in the West Zone who have just come out with this great YouTube video talking about ketamine. Please take the time to review this video. I'll link it in the emails that this is sent out in, and I'm going to link it on this slide as well, just so you have some options. Please take the time to review that and also your shared healthcare map, just to get yourself refamiliarized with safe and responsible use of ketamine. Just for some quick policy related information, we are expecting to be carrying a 2 ml vial with a concentration of 50 milligrams per ml. You are going to notice on the care maps that there is no single max dose or hourly max dose. This is going to be entirely dependent on patient response. This also means that some stations that statistically have longer transports to primary facilities may end up carrying more ketamine than others, and those that have shorter transports to primary facilities may not carry as much ketamine. This is still under consideration, nobody panic yet, but it is in the interest of reducing waste, so we do need to look into it. And just so that I can say that I said it, ketamine is absolutely going to be a slow push delivery and a high alert medication requiring an independent double check. You're also going to notice in your care map that ketamine is not compatible with lactated ringers and needs to be run with saline solution. Okay, you guys, this is a long one. You made it. I'm proud of you. So from here, we have a few things that we're going to require of our staff just to get this education package out and in the interest of closed loop communication. If you have any questions, you can contact your clinical department. We will help you out. And in the meantime, we need you to watch this video. Check, already done. In addition to that, we will also need you to watch the West Zone ketamine video linked in the previous slide. Check. After that, you're going to go ahead and complete the quiz and return to me at my email, thearmstrong@nrha.ca. I will go over the quiz, and again, we can talk about any questions or issues you might have following that. Once you've completed all three of those things, you're going to go ahead and sign the attestation form and again return to myself or any member of the clinical department, and we will get that filed away where it needs to go. Check. Thank you all for sticking with me in this super long video. I hope you guys have a great shift, and I hope you all enjoy the return of ketamine.